Hello everyone, welcome to my channel and today we are going to discuss abdominal pain. So in this video, I'm going to discuss in detail how to take history from a patient who presents with complaint of abdominal pain, what are the differential diagnoses and how to rule them out, what are the red flags that you need to be aware of, what examinations to perform, what investigations to request, and how to provide management to this patient. So first of all, as in every Pleb 2 station, you are going to start by introducing yourself and confirming patient details. Then you are going to start your consultation by asking an open-ended question, such as, how may I help you today? And the patient will give you a presenting complaint, which in this case is going to be abdominal pain. So the next thing is to ask an open-ended question about the presenting complaint. So we'll ask the patient, can you please tell me a bit more about this pain? And the patient might tell you a few specific detail about his pain, but we need to explore it further. So I'll ask Socrates, which is basically an acronym. So we are going to start asking close-ended questions now. So first of all, the site of the pain. We'll ask the patient, can you please tell me exactly where are you feeling this pain? Can you please point it out with a finger? Onset of the pain, can you please tell me when did it start and how did it start? Was it sudden or gradual? Character of the pain. Can you please describe this pain for me? Is it sharp, dull, or crampy? Radiation. So does the pain go anywhere? Associations, anything in particular that brings it on or triggers it? Time of the pain. So is the pain there all the time or does it comes and goes? And any particular time of the day where the pain is more severe? Exacerbating and relieving factors. So anything that makes it worse, anything that makes it better. And while asking exacerbating and relieving factors, try to establish a relation of the pain with bowel movement, position of the body, and food intake, because it can serve as a pointer towards certain specific diagnosis. So if the pain increases with bowel movement, it can indicate something like IBS. If the pain changes with position, if it increases on leaning backward and decreases on leaning forward, then it can mean that the patient might have pancreatitis. Relationship with food intake is also important. It's a pain of peptic ulcer disease and cholecystitis increases with food intake. Okay, so try to establish this relationship while asking exacerbating and relieving factors. Severity of the pain, you can ask about severity by asking the patient to score the pain on a scale of 1 to 10, where 1 being no pain and 10 being the worst pain they have ever experienced. So this was about exploring the presenting complaint. The next thing you're going to do is ask the patient, is there anything else apart from the abdominal pain? Okay. So regarding associated symptoms, I want you to think of abdomen in terms of the system that it contains. Okay, so abdomen contains gastrointestinal system. So we are going to ask about gastrointestinal symptoms. The abdomen contains urinary tract. So we are going to ask urinary symptoms, and it also contains reproductive tract. So we are going to ask about symptoms of STI and PID. And in addition to these three systems, that is gastrointestinal, urinary, and reproductive, we are going to ask about rheumatological symptoms because certain conditions like inflammatory bowel disease also have rheumatological symptoms in addition to gastrointestinal symptoms. And the fourth thing that we are going to do is we are going to ask about systemic symptoms. Okay, so first of all, gastrointestinal symptoms. So we'll ask the patient about any nausea or vomiting, and we are going to explore the vomiting further if the patient is vomiting. Okay, we are going to ask about any heartburn, any difficulty in swallowing, any change in bowel movement, so diarrhea or constipation, change in the color of urine, stool, and itching, which will indicate obstructive jaundice, tenesmus, which is feeling of incomplete defecation, incomplete emptying of bowels after defecation. Okay, so tenesmus, blood in stool. If the patient is having blood in stool, then we are going to quantify the color and the volume of the blood, because if the blood is brighter in color, it means that it's coming from down below, for example, rectum or the anal canal, or a large gut, but if it is more coffee color and brown, that means that it's coming from higher up, like stomach or esophagus. Okay. And in case of diarrhea and vomiting, we are going to explore it further by asking about the color, consistency, frequency, and the presence or absence of blood. And again, if blood is present, then we are going to ask about the color and the quantity. And in a patient presenting with abdominal pain, vomiting, and diarrhea, you are also going to ask about the presence of any sick contacts in the family or friends, because it can mean that the patient is having gastroenteritis. And you should also ask about the history of travel or eating out, okay? Because it's a risk factors for gastroenteritis. Okay, rheumatological symptoms, as I already told you, that IBD can present with abdominal pain, diarrhea, and rheumatological symptoms as well. So you are going to ask about skin rashes, joint pain, and eye redness and eye pain. So these three rheumatological symptoms, keep in mind: skin rashes, joint pain, eye redness, and pain. Okay, then urinary symptoms. So abdominal pain can be because of upper or lower UTI, okay, or kidney stones. So you will ask about flank pain, any discomfort or pain on urination, and blood in urine, okay. So abdominal pain in cases of urinary stone, that is kidney stone or ureteric stone, the abdominal pain will be in the flank region and will be radiating towards the groin, and there will be symptoms, urinary symptoms like dysuria and urgency, and presence of blood in the urine, okay. The third system that we have is reproductive system. Um, so we'll ask about any discharge down below, and we'll also ask the patient to elaborate the discharge further in terms of color, in terms of quantity, presence and absence of blood, and we'll also ask about history of unprotected intercourse. Okay, we also ask about last menstrual period in a female patient, because a female patient with missed menstrual period with abdominal pain can indicate ectopic pregnancy as well. So we need to rule ectopic pregnancy out in a female patient. Then we are going to ask about systemic symptoms. So systemic symptoms like fever, weight loss, and night sweats, okay? Then there are certain red flags that you need to be aware of. So fever is one of the red flag. Fever can indicate a more serious condition. So for example, a patient with fever discharge from the discharge from down below, and lower abdominal pain can mean that the patient have PID. Okay. A fever with abdominal pain with nausea and vomiting can mean gastroenteritis, and if gastroenteritis is severe enough, then you need to admit the patient. Okay. So keep an eye on fever. The second red flag is absolute constipation. That is, the patient is not passing any stool or vent. Okay, this is an emergency condition. Absolute constipation is an emergency condition. You should admit the patient and keep the patient ill by mouth, pass an NG tube to relieve the stomach of its contents, start the patient on IV fluid, do scans, and try discuss with your seniors, and maybe prepare the patient for surgery to relieve obstruction, okay? The third red flag is excessive vomiting and diarrhea, okay? Because the patient is vomiting a lot, or the patient is going to the toilet frequently because of diarrhea, and the patient can get dehydrated, and you need to admit the patient to give them IV fluids. So these are the three red flags that you need to keep in mind. That is fever, absolute constipation, and excessive vomiting and diarrhea. That is dehydration. So this was basically your history of presenting illness. So first of all, we explored the pain by asking Socrates. Then we asked about associated symptoms, and we asked in details about symptoms of gastrointestinal tract, urinary tract, reproductive tract, rheumatological symptoms, and systemic features. And then we quickly discussed about red flags. Now I'm going to briefly talk about differentials of abdominal pain, and then we are going to talk about past history. So in terms of differential, I've divided abdominal pain into upper and lower abdominal pain. So an upper abdominal pain can be because of GERD, okay, peptic ulcer disease, pancreatitis, myocardial infarction, cholecystitis, and kidney stone. So in case of GERD, the patient will have history of reflux symptoms. The patient will complain of heartburn for a long time, and there may or may not be difficulty swallowing. There will be a history of increase in the pain on food intake, um, and there will be presence of risk factor for GERD like obesity, increased alcohol intake, stress, smoking, etc. Peptic ulcer disease, again, the patient will complain of pain in the epigastrium. The pain will increase on eating, and there will be history of risk factors for the presence of peptic ulcer disease. So stress, smoking, taking NSAIDs, etc. Pancreatitis will present with epigastric pain again, and there may be history of excessive alcohol consumption or the presence of gallstones, and the pain will increase on leaning backward and will be relieved on leaning forward. So pancreatitis again will present with epigastric pain, and myocardial infarction can also present with epigastric pain. So keep an eye um, on ECG as well when the patient present with upper abdominal pain, particularly epigastric pain. So these four mainly present with pain in the epigastric region, and then we have cholecystitis, which is due to gallstone, and it can be it is usually in the right upper quadrant, and kidney stone can present with upper abdominal pain either to the right or left, and will be radiating towards the groin. So these were basically differentials of upper abdominal pain. Lower abdominal pain, the conditions that can cause lower abdominal pain are appendicitis. Appendicitis pain is usually in the right lower quadrant. Diverticulitis causes lower abdominal pain, can be either towards the right or towards the left. Ovarian torsion, depending upon which ovary is involved, it will be either pain towards the right side or the left side, the lower abdomen, but it can involve the lower abdomen diffusely. And the same is true for diverticulitis. Ectopic pregnancy can again present with lower abdominal pain. PID, pelvic inflammatory disease, will also present with lower abdominal pain. And UTI will present with lower abdominal pain in combination with urinary symptoms like frequency, urgency, dysuria, blood in urine, etc. PID will have an associated discharge and history of unprotected sexual intercourse. So that was abdominal pain in terms of its differentials, whether it is upper, whether it is predominantly involving upper abdomen or lower abdomen. Okay, and then we have some diffuse causes of abdominal pain. So these conditions involve the whole abdomen diffusely. So intestinal obstruction can present with diffuse abdominal pain along with absolute constipation. So the patient is not passing any wind. The pain is also very severe in this condition. Patient may be vomiting as well. So the patient is not able to pass anything, anything from down below. So they can start vomiting. And there may be a history of previous abdominal surgeries. So previous abdominal surgeries can cause adhesions, and they can then lead to intestinal obstruction. Okay, peritonitis, again, the whole peritoneum is involved, so the abdominal pain is diffuse. Peritonitis can also occur following appendicitis. So if the appendicitis is not treated, the inflammation can spread to the peritoneum and cause peritonitis. Also, if peptic ulcer is perforated, then the whole of the peritoneum can become inflamed and cause peritonitis. So peritonitis pain is diffuse and very severe. Mesenteric ischemia, again, the pain is going to be diffuse. In mesenteric ischemia, the patient is usually old and there is history of heart disease. So a patient with history of heart disease, particular atrial fibrillation, a thrombus can form, and it can convert into an embolus and stop the blood, compromise the blood supply to GI tract. So there is diffuse abdominal pain due to ischemia, and the pain increases on food intake. Okay. Gastroenteritis. So again, Gastroenteritis pain is diffuse abdominal pain along with vomiting and diarrhea, and there will be history of either travel or eating in a restaurant, and there may be history of sick contacts in the family. People who ate the same food will be having the same symptoms. Again, the pain of inflammatory bowel disease, that is Crohn's and ulcerative colitis, is it involved the bowel, like small bowel and large bowel. It is going to be diffuse. IBS, the pain of IBS is also going to be diffuse, involving the whole of the abdomen. Okay. So these 5 conditions is going to give you more diffuse symptoms, which is intestinal obstruction, peritonitis, mesenteric ischemia, gastroenteritis, IBS, and IBD. So this was about the differentials of abdominal pain. Now we are going to discuss past history. So we're going to ask the patient any history of similar pain in the past, and any diagnosis of any previous diagnosis of celiac disease or malabsorption, any previous abdominal surgeries, and if you are suspecting STI, then we are also going to ask about sexual history. And again, as I already discussed, in a female patient, never forget about last menstrual period. Okay, so that was past history. We are going to ask past history of a similar symptom, and then the rest of the past history, that is any previous diagnosis of celiac disease or malabsorption, previous abdominal surgery, and sexual history if you are suspecting sexually transmitted infections. And female patient, last menstrual period. Then we are going to ask MFDOSA, which is a mnemonic. M stands for medications, any medication that the patient is taking. A stands for allergies, any allergies at all. Family history. So family history in terms of if we are suspecting gastroenteritis or the patient is having abdominal pain with diarrhea, we'll ask the patient if there is anyone else in the family who's experiencing similar symptoms. Travel history, and then psychosocial. So what does the patient do for a living? How is the pain impacting their life, etc. So psychosocial history. Then lifestyle questions, which is again represented by a mnemonic cafe. So C stands for cigarette smoking, A stands for alcohol, stands for appetite, and E stands for exercise. So cigarette smoking and alcohol are very important because they can predispose to certain condition. Alcohol in particular is a very important risk factor for pancreatitis. Okay, so this was basically your history taking of abdominal pain. Okay, so just to summarize, you will first of all explore the pain by asking Socrates, then you are going to ask associated symptoms by exploring gastrointestinal, urinary, reproductive, and rheumatological symptoms, and then ask about systemic features. And this is going to be your history of presenting illness. Then you are going to ask about past history of similar condition, past history of other conditions, then MFDOSA, then CAFE. So this is your history of abdominal pain. Then we are going to ask about ideas, concerns, and expectations. And then we are going to proceed towards examination. So in examination, you're going to do GPE and abdominal examination. You will be either, depending upon the station, you will be either asked to perform the examination or you will be given the examination findings just by verbalizing it. Okay, then we'll proceed to the management. So first of all, I'm going to discuss the general management of a patient who is presenting with abdominal pain, and then I'm going to discuss 2 specific examples as well. So you will start your management by explaining your provisional diagnosis. So after asking all this history and after doing your examination, you will have a provisional diagnosis in your mind of what might be the cause of this abdominal pain. So you will explain it to the patient and you will address any concerns that the patient might have expressed when you were asking about ideas, concerns, and expectations. Okay. So this is the start of your management. Then you are going to tell the patient what is your plan today. Are you going to admit him? If the patient is presenting to the accident and emergency department, and you think that the patient condition is severe enough in order to warrant admission, then you are going to admit the patient. If the patient is presenting to the GP and you think that the patient needs admission, then you need to refer the patient to A&E. Okay. And if you are in GP or A&E, but you feel like the patient is well enough and doesn't need any admission, then you are going to tell the patient that you're going to give him medication for him to take at home, so home treatment. So next you are going to tell the patient your plan for him today. Are you going to admit, refer, or give him home treatment? Okay. Then you're going to tell the patient that you'll be requesting relevant investigations. So in case of abdominal pain, you're going to request some blood test, which will include whole blood count, ESR, CRP, LFTs, urea electrolyte, amylase, etc. Um, Scans. So depending upon the condition, you will be requesting abdominal X-ray, ultrasound, or CT scan, and then another test you will be doing a urine dipstick and might need a stool sample as well. Then you're going to give symptomatic treatment to the patient and then specific treatment. Okay, so this was about general management of abdominal pain. Now we are going to discuss in some specific examples. So suppose after taking the history and doing the examination, you have a provisional diagnosis of appendicitis in your mind. So you're going to start by explaining your provisional diagnosis to the patient. So you will tell him that you have inflammation of the appendix. From what you told me and from what I understand, I feel like you have inflammation of the appendix, which is a small pouch-like portion of the small bowel, and this condition is known as appendicitis. Okay, so you explained your provisional diagnosis. At this point, if the patient has expressed any concern in the eye spot, then you're going to address it here as well. Then you're going to tell the patient that we need to admit you to the hospital today. Okay, if that's okay with you. Always try to involve the patient in your planning. So at the end of a sentence, you can say if that's okay with you or is that all right with you, and the patient can then tell you yes or no. So it will become a two-sided conversation. Okay. Then you're going to tell the patient about symptomatic treatment. So you'll tell them, I'm going to give you a medication for your pain just now. And if the patient is vomiting, then you will also give them antiemetic as well. Then we are going to tell him about investigations. So we'll tell the patient that we need to do some tests to confirm our diagnosis. These will include routine blood test, a blood test for an enzyme called amylase. If it's a female patient, then you'll tell the patient that we also need to do a pregnancy test to be on the safe side. We'll be doing an erect chest X-ray. So erect chest X-ray is basically to look for the presence of air under the diaphragm to rule out any perforation because of any perforated appendix. Okay, and CT scan of the abdomen. Um, then we'll tell the patient that please do not eat or drink anything for now. We are going to give you some fluid to your vein and some antibiotics according to according to the hospital protocol. So this here is specific treatment. So pain relief, antiemetics, it was symptomatic treatment. Then we told them about blood tests to confirm our diagnosis, and then we are going to tell about specific treatment. So we'll tell the patient, please do not drink or eat anything for now. And we are going to give you some fluid through your veins, some antibiotics according to the hospital protocol. And I'm going to discuss your case with my seniors. We might need to remove the affected portion of your ball by keyhole surgery. So keyhole surgery is basically laparoscopic surgery. So this was about management of appendicitis. Then next we are going to look at another specific diagnosis. So let's say you have a provisional diagnosis of pancreatitis in your mind. Then again, you are going to explain to the patient that it seems like you have inflammation of pancreas, which is an organ in our tummy and help with the digestion of food. This is called pancreatitis. And you're going to address the patient's concerns here as well. There are many causes for it, but in your case, it seems like it is due to excessive alcohol consumption or gallstones, whatever is the case, because alcohol consumption and gallstone are the two major causes of pancreatitis. So the patient will be having either excessive alcohol consumption or gallstones. Then we're going to tell the patient that we will admit him today. We are going to request some investigations to confirm our diagnosis. This will include urgent ECG, just to rule out, because pancreatitis presents with upper abdominal pain. So we'll do an urgent ECG to rule out any cardiac involvement, NEMI, etc. We'll do routine bloods, amylase, lipase, and CT scan of the abdomen. We are going to give the patient pain relief. Again, we'll tell the patient not to eat and drink anything, to basically let the gastrointestinal tract rest for a while. We're going to give him fluids to the vein to prevent any dehydration. Um, Antibiotics according to the hospital protocol, and we'll tell the patient that we will regularly monitor you and keep you in the hospital until the inflammation is resolved. So this was the management of pancreatitis. So in similar way, you can explain your management of peptic ulcer disease, management of cholecystitis, and other causes of abdominal pain, whether upper or lower abdominal pain. So I hope it was helpful, and I'll see you soon in the next video.